When acute mechanical trauma shears through the vascular endothelium, the immediate result is biological chaos. Cellular contents violently spill into the surrounding environment, and the highly ordered structure of the vessel is completely destroyed. The moment this rupture occurs, the body triggers a strict biological objective: the complete restoration of tissue integrity and baseline tensile strength. To track how the body achieves this, we look at this timeline. Classically, the repair process has been described across 4 distinct stages: hemostasis, inflammation, proliferation, and remodeling. Historically, medical education presented these stages as isolated, sequential steps, a checklist where one phase finishes completely before the next begins. But in physiological reality, wound healing is a continuously overlapping biological continuum. Navigating this continuum requires tracking precise biochemical handoffs between different cellular actors as they enter and exit the wound site. The repair is a cascading mechanical system. The biochemical outputs manufactured in one phase actively dictate the architectural structure of the next. At time 0, the immediate physiological response is localized vasoconstriction. The vessels clamp down to mechanically restrict blood flow. The trauma forces the exposure of the subendothelial extracellular matrix. This newly exposed surface chemistry compels circulating platelets to instantly adhere to the site. This adhesion triggers platelet activation, causing them to rapidly aggregate and form a temporary physical plug. Once activated, these platelets immediately release their alpha granules into the surrounding tissue. These granules contain hundreds of highly specific proteins, most notably transforming growth factor beta and vascular endothelial growth factor. While the platelet plug is forming, tissue factor at the injury site simultaneously initiates the coagulation cascade. This flowchart maps the process, showing the simultaneous activation of both the intrinsic and extrinsic pathways. Both pathways cascade downward until they converge into the common pathway of coagulation, anchored by the activation of factor X. The critical output of this common pathway is the activation of prothrombin into thrombin. Thrombin has a primary vital biochemical function. It takes free-floating fibrinogen and converts it into structured fibrin. To stabilize this fragile matrix, factor 13 performs the crucial step of cross-linking the newly generated fibrin threads into a rigid geometric grid. This resulting blood clot acts as a temporary physical seal, preventing immediate blood loss. The stabilized platelet blood and fibrin clot provide the mandatory physical scaffold required for all subsequent cellular infiltration. Without this exact fibrin blueprint, the next phase of healing cannot begin. Between days 1 and 2 post-injury, the early inflammatory phase takes over the site. The initial platelet activation drives an immediate influx of polymorphonuclear leukocytes. We see these leukocytes, primarily neutrophils, aggressively navigating through the dense fibrin web, actively hunting for external pathogens. Their primary operational objective is strictly defensive, minimizing bacterial contamination within the compromised matrix. Simultaneously, the locally injured tissue and the platelets release vasoactive amines, specifically histamine and serotonin. These amines mechanically increase vascular permeability, widening the pathways to allow even more inflammatory cells to flood the wound bed. This microscopic surge in permeability produces the macroscopic clinical symptoms historically defined in medicine as rubor, tumor, calor, and dolor: redness, swelling, heat, and pain.
The biological terrain shifts again during the late inflammatory phase, spanning days 2 through 3. Monocytes arrive en masse into the wound bed and immediately differentiate into macrophages. The macrophage operates with dual functionality. First, it acts as a phagocytic cell, releasing proteolytic enzymes to debride the dead tissue and clear the wreckage. Second, it becomes the primary local producer of cytokines and growth factors. The macrophage provides the transition between phases by clearing injury wreckage while simultaneously synthesizing the chemical signals required to trigger the rebuilding process. By day 3, the timeline advances into a phase that will dominate the tissue for the next 2 to 4 weeks: proliferation. Cellular dominance completely transitions away from inflammatory macrophages and hands over to highly active fibroblasts. The primary manufacturing role of the fibroblast is the rapid production of ground substance, a dense biological gel rich in complex glycosaminoglycans. Its secondary manufacturing role is the synthesis of early, unrefined collagen to quickly fill the massive structural void left by the injury. We recognize this newly formed biological filler clinically as granulation tissue, easily identified by its bright pink, granular appearance. Because working fibroblasts demand immense amounts of oxygen, the tissue undergoes concurrent angiogenesis, constructing entirely new blood vessels on demand. At the superficial layer of the wound, a simultaneous process of re-epithelialization occurs to restore the outer barrier. Deep within the matrix, a critical cellular adaptation occurs. Standard fibroblasts differentiate into specialized myofibroblasts. The myofibroblast is a highly contractile cell, engineered entirely for mechanical leverage. Watch these myofibroblasts exerting immense physical force. They contract their cellular bodies, gripping the matrix and forcefully pulling the distant edges of the wound together. The proliferative phase successfully replaces a fragile fibrin web with a highly vascularized, physically contracted biological patch, yet this new tissue remains structurally inferior to normal skin. At 2 to 3 weeks post-injury, the tissue enters the final and longest stage, the remodeling phase, a process that can last for well over a year. The overarching biochemical objective of this final phase is the complete maturation of collagen. The rapid, chaotic collagen deposited during proliferation is primarily type 3 collagen. It serves as a quick filler, but it lacks robust structural integrity. This animation shows the slow, systematic replacement of type 3 collagen with thicker, stronger type 1 collagen. The body aims for an exact target, re-establishing the 4-to-1 ratio of type 1 to type 3 collagen found in normal skin. The new type 1 collagen undergoes intensive cross-linking, aligning uniformly to maximize its load-bearing capabilities. This invisible molecular cross-linking translates directly into a macroscopic increase in the tissue's tensile strength. This graph plots structural recovery. Tensile strength climbs steadily, peaking at 12 weeks post-injury. However, scar tissue has limitations. It never regains full resilience, plateauing permanently at 80%